Art, you're not an orthopod, so maybe this isn't the right question for you, but what are the similarities between carpentry and medicine?
Yeah, Jeff. So I think I mentioned I did carpentry before med school, and the
Absolutely did.
connection is building things. So I consider myself an entrepreneur. Started a company, and getting the gratification of building something, just like putting something together in wood.
Absolutely. We'll dig further into that later. But welcome back to How It's Med, the podcast where we chat with brilliant inventors, founders, funders, and physicians who are shaping the healthcare systems of the future. We learn about the stories, secrets, and skills that these amazing people leverage to make their impact so that you too can be better prepared to make the future of healthcare more accessible and of higher quality. This time around, we're interviewing the inimitable Dr. Art Papier, artist, printmaker, carpenter, dermatologist, and CEO and co-founder of VisualDx, a diagnostic clinical decision system that reportedly boasts the world's largest, most equitable professional medical image collection. Art, how are you doing today?
Jeff, I'm doing great, and thanks so much for having me on your podcast.
Really appreciate you making time to come on. I know that you wear 5, 6 hats, but I appreciate the fact that you came on regardless. Jokes aside, Art, we had a chat a couple months ago, and you highlighted that you were a carpenter, that you did so much before medicine. It was a rather unconventional journey. Was there that influence from your pre-medical career in your decision making to decide on dermatology, or was that decision serendipitous?
Well, it was a combination.
Hmm.
I ruled out a lot of things during medical school, and I had a really good friend, Dr. Bowers, who pointed me towards dermatology. And, you know, there is obviously that visual connection between this art background and thinking about graphics and visuals. So ended up at dermatology, not only from looking at rashes, but also looking under the microscope. It's really like a truly wonderful specialty because you can really close the diagnostic loop. You see the patient, sometimes you do a biopsy, then look at the pathology of the biopsy of the patient they saw the rash on. So you really have this training loop between what you're seeing clinically and then what you're seeing microscopically that really cements the disease process for you. So that was really rewarding for me. But I didn't know that when
Mhm.
I decided to be a dermatologist. I think it was really this whole interest in pattern recognition and thinking about visualization of information.
Yeah, fair enough. And I mean, that segues well into the next question, which is kind of about your interest in medical informatics and patterns and knowledge gathering in medicine. I know that one of your mentors that you mentioned in our previous conversation was Dr. Larry Weed, who created the all famous SOAP medical format that I use, that so many residents and staff use all over the world now, and that he influenced your decision towards medical informatics. To kind of start the conversation that we're going to delve into, can you explain to me what medical informatics is, like you would to a 5-year-old?
I would say it's the field of using computer or now smartphone based computerized information to improve clinical medicine. And I'm describing clinical informatics, not bioinformatics. We're more talking about computational research around how do we improve the delivery of care in the exam room. And I would extend that to include the patient at home as well.
hmm And to delve a bit deeper into that, how exactly does computation improve the clinical, I guess, experience or clinical performance overall? And maybe zoom further back, how did informatics make an impact back in the 1990s?
Well, there's a couple of questions tied together there. One
Fair
one
enough.
is like, what was medical informatics accomplishing in the 1990s? And I would say not much. But then, what were people trying to do as early as the 1960s? I think that many realized that the human brain isn't really powerful enough to deliver consistent, highly reliable care every 20 minutes in complex situations. And You mentioned Larry Weed, and I always kind of frame it um, through my work and the lens of Larry, who taught so many generation there of internists in the 60s and 70s before me about the need for systems of care rather than relying on the variability of different humans. And so, often people use the example of aviation to describe, the difference between medicine and aviation, where pilots have rigorous training in a cockpit simulator and have checklists, and they follow exacting process. And the communication standards are very precise to talk to the tower a certain way. So, if you fly in a plane for Southwest or you're a passenger on United, you're pretty sure that your pilot has a consistent behavior to deliver you safely on, takeoff, flight, landing, taxiing, all happening the same way. But you go into a modern medical center, even some of our best, on the same hallway, you might have tremendous variation between the different physicians, because one trained in the South, one trained in the North, one trained in Europe, and there's just different habits. And so I think this was pointed out by Larry and others 50 years ago, that it's a recipe for disaster when you have just like a cottage industry with no enforced standards.
That's fair enough. And if there's such a need for standardization because humans aren't wired to gather so much information and synthesize it every 20 minutes, then why was medical informatics not making, I guess, much of an impact in the 1990s when computer systems were actually advanced enough to do so to an extent?
I'd argue it's not even making much of an impact in 2023 relative to what it could do. I mean, look, there's cultural and economic reasons why it's so hard to change medicine. And the standard that we have still really is memorization and studying for your boards. So we're saying, to med students, use the best evidence as possible. We want you to look up in journals and bring all this evidence to bear in your decision making. Yet the final bar is to pass your boards. And so you have students that are spending lots of money for their board review, course, study aids and all that, so that they can pass their boards, which is really feats of memorization. And so now they're trying to shift that a little bit to clinical reasoning, right? So you're not really doing the boards just about what you can put in your brain. But for the last 50 years, the standard has been that, you go to med school, you do your residency, and now you're a busy family physician or nurse practitioner, and you're supposed to be highly reliable every 20 minutes when a patient can come in with a different chief complaint of 500 different symptoms that a patient can complain of. And you're expecting this human to take what is currently known in medical science and deliver it to that problem of that patient reliably every 20 minutes. And Larry Weed said it was a myth 50 years ago. It's still a myth. And yet that's the majority of what's done is that kind of behavior. So you have, in medicine today, you have some incredibly creative problem solvers that are using all kinds of tools in the exam room to help them answer these questions. And then, as I said earlier, the exam room next door, the problem solver isn't even looking at a book, never mind a computer. Like they're trying to do everything out of your brain, which means that they know everything. And I don't know everything. I hardly know dermatology, like there's so much to know.
Fair enough.
And Larry said we get away with it because 80-90% of the time, common things happen commonly. And so you can diagnose 80% of your patient visits correctly and offer the right treatment correctly 80% of the time. But we're doctors for the 20%. We're not doctors for the 80%. Because you don't need doctors for 80% because it's easy. You wouldn't need to go to med school to diagnose strep throat or otitis or something common.
Mhm. Mhm.
Doctors to solve the 20%.
So then to dig a bit further into what has improved between the 90s and now, has there been any improvement in your eyes? And if so, what?
Yeah, I think we're slowly getting there. Change is hard. Everything takes time. We're all impatient. We like it to change overnight, but the reality is we're moving an ocean tanker.
Yeah.
It doesn't turn on a dime.
Yeah.
And so we are seeing bright spots. I mean, when Hippocrates came out on the Palm Pilot, I don't know how many years ago, then ended up on a smartphone. We moved from this huge book, the PDR for drug dosing, to just being able to type into Hippocrates and get a reliable dose. And so people forget about these small advances like that, where you now have highly reliable drug reference in your pocket. And that makes you more efficient, more accurate, et cetera. And now you have that built into the EHR. Now we could have a whole show about like the poor engineering of the EHR, right? We could talk about that for probably 5 hours about what we tolerate in terms of antiquated design in EHRs. But there is progress now in that we're able to see what our colleagues were thinking, or you're a radiologist and you want to know what's going on clinically with the patient. Instead of having to hunt down the doctor by telephone, you go into EHR and you see the patient's medical history to help you think through the problem more richly. So we are making progress. But what's frustrating, my friends and peers that are up to, 9 o'clock at night still doing their Epic notes, or, the overcrowded inbox from too many messages. We've created problems as well as solved problems.
Mhm. And talking about problems, what is the single greatest problem that you think, if solved, would lead to a faster change of that giant tanker that is medicine towards excellent care?
Our greatest need right now, our greatest challenge is primary care in America and around the world. So, we're highly specialized in medicine here because we all want to have mastery as human beings. Public thinks all the doctors want to specialize to make a lot of money. I don't think so. I think most doctors specialize because they want to have mastery in a field so they feel competent. The wonderful people that go into primary care are totally underappreciated. This is our greatest problem. Primary care and primary care internal medicine, urgent care, and perhaps emergency medicine, these are the hardest specialties with the most burnout. This is the biggest problem area. We have to support people in primary care because patients don't, when they have complex medical problems, don't know they go to the neurologist or they go to the gastroenterologist or the cardiologist. They're going to go to urgent care, primary care. We have to support these people so they can deliver highly reliable care. And they're burning out, and it's a hard job. It's not paid enough. And we need to think about how do we redesign primary care.
Mhm. And what changes to medical informatics or its practice currently would best allow us to support primary care physicians?
Well, that's also another probably 3-hour conversation, but um, we're just riffing here. It's a podcast, so we're riffing, right? Um, I would say that we need electronic medical records at work. They need to have easy input and understandable output. And we need to create a system where patients can be listened to, where we're not rushing the doctor because they have too many people to see. And we have this problem with churn. So we have to think about how do we bring information to the fingertips of the problem solver that doesn't overload them. It's not TMI. And so we have a tremendous problem with note bloat. I think we have to return to the basics. We have to return to like, what problems am I trying to solve for my patient in partnership with my patient? How am I collaborating with my patient to understand their problem? What are their symptoms? What are the tools that I'm going to use to really bring the best information right to the moment to help ask the right questions and take the next steps? And so really essentially the problems for a clinician are, what's the diagnosis? What are the best tests to order? Do I order CT or ultrasound? What lab studies do I order? My assessment, the diagnosis. Now, what therapy do I order that's contextual to the beliefs of my patient? What my patient really wants that's safe and efficacious? And how do I help this patient understand all my Latin speak and all the confusing words that I use? So it's really diagnosis, testing, treatment, and patient understanding that we need to improve. And that's all in the context of, tons of hype about what we're going to do in terms of health IT.
Hmm. So to connect that to your work with VisualDx, that the melding of your interests in medicine and the troubles that we face in medicine with your interests in medical informatics seems to have resulted in the founding of VisualDx. So what's the story behind the founding of the company?
Yeah, see, like all good work is derivative. It's very rare for someone to come up with something that's totally out of the blue, right? So, I always reference Larry Weed because he's the reason I'm on this podcast. If I hadn't met Larry Weed, I would never have become involved in medical informatics. I mean, the year was 1984 that we're talking about when I met him as a medical student. And he was talking about for 15 or 20 years, he started talking about in the 60s, this idea that we need to bring computers and structure and standards to our thinking. That's, why he invented the subnote format and the concept of the problem-oriented record. And that was a really revolutionary idea in its age. And people to this day, really don't even understand it, because when you look at a problem list in a hospital, 99% of the time, the only thing you see in the problem list are diagnoses, which means that we know the diagnosis for sure. I would love to see in a problem list, unexplained headache, unexplained diarrhea, unexplained chest pain, unexplained rash, where, a workup was done and then you still weren't sure. So your problem list had unexplained symptoms, because that was the idea of a problem list. You kept the patient's symptom in the problem list until you had a firm diagnosis and you had a basis for the diagnosis. And therefore the problem list was trying to prevent premature closure and anchoring. So once you put that diagnosis in the chart and then somebody else picks up that chart or, looks at it electronically, then they're locked into this prior diagnosis and getting off that anchor of that prior diagnosis. So there were really revolutionary ideas that Larry had about, using the structure of the record to improve our thinking. And that's why the paper in the New England Journal was called Medical Records That Guide and Teach. And so the idea was to have a medical record that would have structure that would aid your thinking. And by having a checklist or having a problem list or a problem-oriented record, the checklist frees up the pilot to know that they're going through the standards that they need to go through. And the problem-oriented record was, with that regard, kind of like a checklist to structure the thinking. And now fast forward 50 years. So we're trying to bring to electronic charting something that guides and teaches. And who would say that the current EHRs, without naming them, really guide and teach? Really, they were invented around the idea we have to raise our billing codes. How do I charge a higher level E&M code for the CPT so that my hospital gets paid more? So that encouraged note bloat. And then we have all this copy and paste in the record, and who knows what the truth is. And then they say, okay, well, we'll use ChatGPT to distill the truth, or we'll do ambient listening. But then the challenge is still bloat. And how do you get to the crust of the issue? Like what's the patient's problem? what's the objective data and how am I going to assess it? And so, there's still, as there was 50 years ago, there's not enough attention to how do we improve thinking in medicine, because we're still basically thinking by the seat of our pants in the exam room. We're just relying on this thing. And this thing has a lot of problems.
And how exactly did VisualDx come about in order to solve those problems?
Okay, so met Larry, and he turned me on to this idea, and I worked for him for free during med student evenings and weekends. He was like the best at working with students and convincing them to paint the fence with him. And so he basically sat me down. He said, Art, you sit here and I'm going to teach you how to read the literature. You're going to come over after medical school and work for me on nights and weekends, and I'm not going to pay you anything, but you'll learn something. And so I did that. And then I fortunately ended up in dermatology right when this company, you're too young, you don't remember Kodak, right? You probably never put a roll of film in a camera, but there was this company in Rochester, New York called Kodak that was the equivalent of what Apple is today in the 1950s and 60s, where every roll of film was money and profit to this company and paper to print your pictures. And they were announcing scanning film to digital right when I moved to Rochester in the early 90s. And so the light bulb kind of clicked that I had spent all this time with Larry, and we're just thinking from an internal medicine point of view and realizing how different dermatology is, because in internal medicine, it's history, the subjective. So, subjective, objective assessment plan. Dermatology is really objective, subjective assessment plan. We want to teach our residents to look first, describe what they see, and not be biased, right? So, because you have that skill, you can look and you can describe. So the example would be a patient goes in and says to the primary care doctor, I was out hunting and I leaned over and this branch caught my scalp and it's not healing. I had this wound in my scalp for a month. And the doc looks at the wound and is then led down the wrong path by that history. Listen to history. And, to get the history of the wound hunting, instead of looking, a dermatologist just say, I don't need the history, let me look. They look and they see the pearliness and the telangiectasias of a basal cell. So a basal cell cancer often bleeds, and people like to make up rationales for their denial. So instead of thinking to yourself, oh, I might have a skin cancer, you think, I'm a hunter, I was out hunting, I got a wound in my scalp, and now I can't believe I'd have skin cancer. So the subjective could lead you down the wrong path. So dermatology is totally different. You start often with what you see, pattern recognition. And so really it's VisualDx is the coming together of thinking around both analytical thinking and pattern recognition thinking. And the book to read about this is Thinking Fast and Slow by Daniel Kahneman, who talks about system 1 or system 2. And it turns out in medicine, we don't know which side of the brain we're going to use. And you have to do this incredible context shifting all day long. If you take the job of an emergency physician, where sometimes it's just instant pattern recognition, they know exactly what's going on right away. And on the other hand, they have to get that history. They have to get a lot of lab studies, radiographic studies, and put it all together. And it's all system 2 versus system 1 pattern recognition. So VisualDx is really a coming together of trying to make computing and medicine much more like an Apple experience. Like, what I'm passionate about is good design. And right now we have a big push in VisualDx towards a new version of VisualDx around some design that changes that we think will speed the use of the tool, right? And so we are passionate about this idea of not just having like an elegant spreadsheet, which is what most EHRs are like, to something that really visually is as good design as compelling.
That's fair enough. And I think that's super applicable to the current practice of medicine overall, with the overwhelming amount of data that we have and the amount that we're supposed to synthesize. But to go back to the beginning of this conversation, VisualDx has access to, and I quote, the largest and most equitable collection of professional medical images. So, was this intended focus of the company to build a moat, or was it a serendipitous feature?
We in a memory-based system, we teach to the classic. We say, if you're looking for psoriasis, look at the elbows, the knees, and scalp, and you'll see these scaly plaques. Or you're looking for Lyme disease, you teach the students, look for an expanding bullseye. And you have these classic prototypical examples, but once you practice in medicine for a while, you quickly realize that the patients don't come in like the book, right? And so we realized right at the inception of our work to really do dermatology in the digital space that you have to show the full expanse of the way patients present. So they can present mild or severe, early or late. The rash could appear in different body locations and look different in different age groups. So seborrheic dermatitis, a common condition, can look very, very different in infants and children than it does in the elderly, as an example, right? And then immunocompromised patients present very, very differently, particularly when they have viral illness. So there's all this variation. And then we realized right away that, of course, erythema, redness, and purpura, leaking of blood into the skin, looks very, very different in brown skin. Red and purple on brown just looks deep brown. It doesn't look red or purple. So we got very interested in this right at the beginning. We started collecting the spectrum, and then we realized that we couldn't do this really out of just collection in Rochester, New York. So we started partnering with people that were passionate and are still passionate about medical photography, right? Which is kind of a lost art now, because there's this paradoxical thing that this wonderful tool in our pocket does. It makes photography accessible to all, and everybody just takes a quick picture, but the picture's nowhere as good as a picture taken with a large 35 millimeter camera, whether it's digital or film, with those bigger lenses, with the right lighting, the right background. And so right in the beginning, because of my background, I was very interested in like really high quality imagery. And so at VisualDx, we're not a wiki model. We're not saying everybody just send us pictures, right? So we've been fortunate enough, and the other great influence in my career and my life was Lowell, and is Lowell Goldsmith, who was my mentor and chair of dermatology when this all got started, and is my partner in crime in this. He's our editor in chief still to this day. And Lowell is, this genius, clinician, researcher, humanist, and Renaissance thinker who was very open to these ideas and knew nothing about computing when I met him in 1990. Like, he just was open-minded to it. He says, sounds interesting. And he's like, send Kodak a letter. We'll give it a shot. Right. So you have to have great luck to meet great people and listen to them and try to learn from them. So I consider myself really lucky.
Hmm. Okay. And it seems like that was a pretty laborious process to build a high quality medical imaging database. But the other part of the phrase that VisualDx really brands itself on is equity in medical imaging. Why is equity in medical imaging so important to the company?
Um, yeah, bias in information, right? It's just readily apparent. And, I had a medical student that worked with me, Toby, back in 2006, and we published a paper called Disparities in Dermatologic Resources. And I had Toby go through every leading book at the time and count the balance of images, light skin versus dark skin. And we just had we had a measure of how little teaching and training that was going on diagnosing and understanding disease in people of color. And so I don't know why it's always bugged me. It just bugged me. Our company's a very humanistic company. So we're doing, since our inception, we've been doing a lot of good in the world. And right now we have a project, our second project with the Gates Foundation. It involves neglected tropical diseases with work that started in Botswana and, contacts throughout Africa. And then we're working on a project that's gone very, very well with the federal government around Mpox, what we used to call monkeypox, which affects, people that are discriminated against too. And so, when you think about medicine, you think about what's really difficult. You look at patients that don't have access. They still don't have insurance. They don't have the money to pay for the therapies. And there's all this bias. And so, I've always thought these people are getting not only less access to doctors and less therapeutic therapies that are accessible to them, but the people taking care of them really don't understand the dynamic enough of what patients that have been discriminated against. So it's really just kind of always annoyed me. And we have a company now of 80 people that love this mission of trying to improve care for people in need.
Overall, I think that's an absolutely great take to see how we can improve access to care and quality of care. That's something that I deeply agree with. But to go back to the imaging database, my initial assumption would be that with a high quality imaging database, a company would go for a algorithm to recognize different lesions and to allow for better, more accurate diagnosis. But instead, your company brands itself as a clinical decision support system, or that its product does that. Can you explain the thinking behind this branding or this differentiation from what I assume the company would have done with its core asset?
Yeah, well, we have a product called Derm Expert where we're using machine learning, and we have exceptional research going on in using this corpus of imagery to develop machine learning algorithms. So I don't know if you've seen it, but you can open our professional tool and do machine learning and be guided through it. Now, we don't brand the company as just an AI machine learning company. And of course, we're working on large language models, and we're working in this field of machine learning for 5 years. But solving the problem is not going to be solved just through machine learning. Yes, I believe you'll see in the next few years incredible algorithms created for telling you if the mole is a normal nevus mole or it's a melanoma with a high degree of confidence. And similarly for other conditions, there's already, applications that are approved for diabetic retinopathy that are more accurate than ophthalmologists. So these binary questions, is it this disease or not? You're going to see rapid advances, and you're already seeing it in radiology. So the visual specialties, not just derm, but radiology and ophthalmology, are just taking off with machine learning. But as I said, when we were talking about system 1 and system 2, it's not always system 1. And a picture is not always system 1. And I always use the example of a patient comes in to see a dermatologist and has, pink spots scattered all over their body. And, the non-dermatologist would call it a maculopapular rash. And a dermatologist would get offended and say, look, they have an exanthematous or morbilliform eruption. And what's the diagnosis? They show you the picture, or the patient comes in with pink spots, and you say they have a exanthematous eruption. I can't tell you what the diagnosis is. I need to know, did they take amoxicillin last week? Did they travel overseas? They traveled to the Caribbean. Do they have a viral infection? Do they have mono? Do they have a sore throat? You need to ask other questions. You need to put the whole thing together, right? It's not just a blank moment, right? So obviously you can feed the history into the computer too, and the image into the computer, and start to get, a good differential. And that's where we're moving, right? But when you're talking about hundreds of diseases in 2023, there's no algorithm that can statistically be accurate enough that you can go and market that as diagnostic. That would be unfair because then doctors would over rely on it, patients would over rely on it and think that it's right all the time. You can do that for one or two diseases with confidence, right? Like the algorithm, machine learning can say yes or no. This looks like it's a brain tumor. Yes or no, this looks like lung cancer on the CT to aid the radiologist. But when you're talking about hundreds of diseases, just take a picture and expect the software to accurately and reliably give you the answer for hundreds of diseases. I'd be impressed if somebody could show me that doing that highly reliably today
Mhm.
without error.
And to
So we argue, at least today, it's augmented intelligence. Can I give you a tool? Can I give you a tool that makes you much better than you are practicing without the tool?
Okay. I mean, to build on that conversation, a product that VisualDx has spun off is ASA. ISA. How do you pronounce it?
ASA.
ASA. So for context for the audience, it's an AI patient-facing symptom checker. So your company's already moving in that direction in addition to the machine learning work that's already being done. So if there's the role for augmented intelligence in medicine, what is the role of AI in medicine and what is the role of the physician in medicine overall? And if we think into the future, um, are the two players, AI and healthcare providers, complementary or are they overlapping to a large extent?
Well, I'm in the camp that complementary. If you think the software is so wonderful, then we can just stop training doctors and nurse practitioners and PAs. But the reality is that I think we're always going to need good physicians, and good physicians are going to be defined by how they use information and also how good their hands are. I mean, you don't want to go to a surgeon that has no manual dexterity. I mean, you need somebody who has great eye-hand coordination that's laying their hands on you to do a procedure. And of course, then there'll be robot assisted surgery, et cetera. But we'll just keep getting better and better tools. Like carpenters started with a handsaw, and then you got to like circular saws, and then you got to, incredible table saws that you can take that fence and dial it to 1/32 of an inch and know that that board is going to be cut precisely at 1/32 of an inch. And you couldn't do that with a handsaw, right? So tools are what humans create tools. And in medicine, we've been slow to create useful tools, right? And our thesis at VisualDx is that useful tools in medicine are not just lists of words, that we have to figure out what's the balance of the words, the graphics, and the images, and the machine learning, the large language models to come together to create a unified patient experience that involves the patient as part of the loop. Because we know that people, I shouldn't even call them patients, people are going to go to Google, they're going to go to ChatGPT, they're going to put their symptoms in, they're going to wonder, is ChatGPT correct? And often ChatGPT will be more correct than their doctor, maybe, right? So you got an asymmetry there. And so it's a forcing function in a sense that these great tools are going to be out there for patients because if your patient comes in and knows something from the internet, um, it can be embarrassing. Now, I'll tell you a story that's really interesting. So years ago, I had a resident, Sammer, and a child come in the exam room, brought in by the mother, and my resident Sammer says to me, "We got this child in exam room 6 that has hair loss and being treated for ringworm of the scalp by the pediatrician." So I said, "Okay, let's go in the exam room and see the patient." So we go in the exam room and see the patient. Say hello to the mother. A teenage sister of the boy was standing next to the mother against the wall. And so I say, "Samuel, let's say hello to the boy." We examine the scalp and all these pustules around the scaly plaque, which is a sign of a complication of ringworm of the scalp called carion, Kerion. So immediately I say to Sammer, I say, "Look, there are pustules. This is a carion." And as soon as I say that, the mother goes ballistic, turns to the teenage daughter and says, "You see, that's what I said it was," but she wouldn't listen. And I turned to the mother. I say, "What's going on here?" And Sammer rolls on the rolly chair back to the computer, right? And I'm saying, I'm very interested in information in medicine, computers in medicine. Tell me what happened. Because it was obvious she was on the internet. And she says to me, well, and I say to her, "Do you work in healthcare?" And she said something like, I work as a administrative assistant or something in the cancer center. And when my when my boy's sick, I'm going to be looking things up on the internet. And by then, Sammer's in front of the computer. And I'm saying, "Well, what happened?" She said, "Well, he had a rash on his face, and the doctor felt it was ringworm of the face, gave treatment for it, it got better. 2 months later, his hair started falling out. I went back to the doctor, and the doctor said correctly, there's now fungus in your scalp. A month later, still not getting better, takes the child back. The pediatrician says, keep taking the medicine, right? Child's still not getting better. So that's when she goes to the internet and searches ringworm of the scalp, reads in WebMD that a complication is a carrion, Google's carrion, and ends up on our patient-facing site called SkinSight. Because what happens, Sammer goes over and Google's carrion and Google, and at the time, SkinSight, our patient-facing site, was on the first page of results for carrion. So he tilts the monitor to the mother. Mother says, that's where I was. I said, Sammer, people diagnose through telemedicine easily, but I think we have the first case of creating software for patients where we helped them figure something out. It was a total coincidence that this mother ended up in our exam room after we created this website and that she had landed on this website. So what happened was she prints we have an ability to print the page. So she prints the page and she takes the kid back to the pediatrician, which took a while to get in, and says, I think my boy has a carrion. And the pediatrician says, who's the doctor here? And so the mother says, I'm done. I want my boy to see a specialist. She says, I'm done. And it takes 6 weeks to get in to see us because they're busy academic dermatology practice. So 6 weeks later, she comes with the child. I come in the exam room. It's a system one blank moment for a dermatologist. And we go, it's a carrion. Right? So in the future, ASA, I don't know if ASA is trained for the scalp yet. I have that memorized. Like we cover like 200 diseases and it's supposed to educate and guide just like SkinSight. And so this balance of, then the software could be wrong, right? And then the parent or the patient comes in and with their ream of internet handouts and they become fixated that they have this disease that they don't have and they don't trust the doctor. So it's a double-edged sword. You want well-informed patients. We all want well-informed patients, but we've all experienced these patients that are locked into the wrong thing. And now, post-COVID, we have a complete diminution in trust where a lot of people don't trust their doctors anymore. They don't trust public health anymore. So this double-edged sword of the internet is both a great thing and also something that's actually making doctors' lives more miserable when it's wrong, right? So there's fantastic challenges, and your generation will have to fix it all.
So in the context of AI being made available in the form of ASA, for example, to patients where there can be accurate diagnoses for very specific niches of medicine, what is the role of the physician in this augmented intelligence model?
More and more information will be shared with patients directly, and they are going to come to their clinicians with their interpretation of the information that they received. And the clinician is going to have to educate and inform and balance the information that people receive through the resources they use. And it's going to be a lot of work. to transform the system from one where I'm paternalistic and I say, you have this, you're the patient, trust me, right? Because that just doesn't work anymore. Especially when you have really well-informed patients and they have a lot of information and you don't, as a generalist. Again, it's a really hard job being a generalist, right? You have to have humility. You have to be able to say, I don't know, let's look it up together, right? I have some professional resources. Let me show you how I solve this problem. So I think the way we solve problems, and this is the way we designed ASA, is we designed ASA actually to kind of recapitulate how doctors solve problems. So it actually shows you the type of lesion before it gives you the list of possibilities. And so you're double checking, you're understanding that your rash is being put into a category. So we're really trying to live up to this idea of like AI that guides and teaches. And it's not going to be good enough just to have, oh, the AI says this, totally trust it, done. The autopilot always works, right? At least not in the next few years. I mean, who knows? Maybe it'll be so great that the only thing doctors are doing are the procedures.
Mhm. So, I mean, it seems like from that answer that the role of the clinician, or at least the the generalist, is to work alongside the patient who has access to more and more expert knowledge to arrive on a diagnosis and a treatment plan in a more cooperative manner than prior. Correct?
Correct.
Okay.
I would agree with that. I'd say collaboration. The clinician will be the expert if they have expert tools. But if they don't have the expert tools and the patient has some expert tools, there's going to be this asymmetry in the conversation that is going to really hurt trust between the patient and the doctor. The doctor is going to have to be able to handle the information the patient has.
So then, to build on that, if there is that threat of trust being fractured or further, I guess, eroded, just even based off of like previous current events, why did VisualDx choose to focus on SkinSight and ASA as consumer-facing tools?
Well, we have this competency and we know there's a need. And we just looked at what was out there and we thought we could do so much better than, other websites that handle skin. And we have this leadership in dermatology that I think is cross-cutting, not just for patients, but for medical students. We've created this fantastic website. It's now in its fourth generation called Learn Derm. That's for free. And we have students around the world using it. And we're currently translating it into other languages. And so we have this leadership in dermatology. And when people ask me, what do you do best at VisualDx? I would not just say dermatology because, the term dermatology is very pejorative. It means kind of, to a lot of people, it means acne and psoriasis and warts and skin cancer. To me, it means the ability to look at a rash and diagnose, right? Like what really our residents get out of dermatology training is to be able to diagnose some internal diseases, serious rheumatologic disorders or infectious disorders. So we've been very, very focused on not just dermatology, but infectious disease. Now you can get in VisualDx a differential diagnosis across medicine, but the sweet spot for us is infectious disease. And another 3-hour conversation would be about how climate change is affecting infectious disease and the movement of disease around the world and into this country. So, there's just an article in USA Today this week about endemic leishmaniasis in America, that there have been cases reported in JAMA about patients that had not traveled that have leishmaniasis. So that sandfly that can transmit leishmaniasis is probably on the move. And similarly with ticks, I mean, Rocky Mountain spotted fever used to be mostly in the Carolinas, North Carolina, South Carolina. Now the ticks are moving, mosquitoes are moving. And so this area of designing and developing databases that can capture the range of diseases and help with differential diagnosis and context So that's what's so powerful about the work we're doing is not just to think this is a single machine learning solution of an image of dermatology, but we're really developing a platform to consider how do you diagnose these diseases that range from rare diseases to variants of common diseases.
Mhm. To kind of wrap up the conversation here, VisualDx has been around since 1999, and in the startup world, that's eons. So why has it been around that long? And do you think now, reflecting back, that an entrepreneurial approach to the problems that VisualDx hopes to solve is and was the correct approach?
Um, what the question isn't precise of me. So is the correct approach so that VisualDx goes public and it's made $1 billion, or is the correct approach to have real world impact, right? So, and to make money, to be a profitable company. And so you have to make choices. And certainly, you could morph your company and just become an, an advertising company, or you can decide, I'm going to make money trying to do the right thing. And that's hard. The economic forces are very, very different from doing the right thing when, you're billing in America in a fee for service system, which means that quality is not rewarded. Speed is rewarded. So there's often an inverse relationship between speed and quality. And so the economics of American healthcare are around speed and churning through patients. That's the economic force. And so, physicians are really unhappy because they didn't become a physician to become a mill. They became a physician to help people and listen to people. And so in that context, I think we've done exactly what we should do. I never thought it would take so long to get to where we are, and we have a lot more work to do, but we're making incredible progress right now. We, not only technically with like machine learning and the research we're doing now with large language models, but in terms of the adoption, we now have over 110 medical schools teaching with VisualDx. We have incredible success stories. I was just up in Vermont and told the story of a family physician during residency, family medicine resident, that a patient was admitted for fever and a rash through the hospital. The ER didn't know why the patient was so sick. And using VisualDx, the family medicine resident figured out the patient had bacteremic Lyme disease. So in bacteremic Lyme disease, you can have multiple patches all over your body. It's not a single bullseye. Of course, through memory, we teach students memorize the spreading bullseye. We don't say, oh, and there's an exception, lots of patches if it's bacteremic. And this family medicine resident figured this out 10 years ago. This is a case from 10 years ago I was just sharing with the residents that are in training now. So we've been having that kind of impact for years, and it's snowballing. We're starting to get these stories, and we're starting to see people say, I love VisualDx. I use it all the time. Are there things that we're going to make better? Of course. Do we need to really innovate with the language part of large language models? Of course. But you have to, in medicine, it can't be just a black box where you say, oh, well, ChatGPT came up with the right answer. Well, how do we know it's not biased? How do we know it's not hallucinating? How do we know it's right? Right. So what we're trying to do is really stay true to core values, which is keeping the patient first, trying to be highly reliable, and taking care of people.
hmm And to finally wrap up the conversation, I offer a chance at the end of all the conversations for the guests to plug anything that they would like to. Is there anything that you'd like to highlight to our audience?
Well, if you have anywhere from a student all the way up to a practicing physician or a faculty member, VisualDx, you can get a free trial. You should reach out to us because there's such a thirst for professional information and to level that playing field. Your patients have Google. You all should have a professional tool. And VisualDx has a peer-reviewed editorial board, and I would argue it has the highest quality professional images so that you're not hunting and pecking around Google to see inaccurate images. You're actually getting highly reliable imagery. So that would be my plug.
All right.
Check out VisualDx. Be in touch. We have a great team. It'd be great to hear from your audience.
Thank you so much.